Here's the thing that I like to tell people and also clinicians.
Yeah.
If you've never had a depressive or anxiety episode, that impacted functioning, and you start to experience new onset symptoms in these perimenopausal years, let's say 35 to 55.
Yeah.
It's probably most likely due to these hormonal shifts in whole or in part, right? Because it's complicated, the pathophysiology of it.
Yeah.
Right? But that's the way we should think about it. Like the perimenopausal years are a risk factor for depression, anxiety, insomnia, stress, and many other things, all the physical health changes related.
Right. Okay.
So we need to know that. And I think if we know that, we can prepare ourselves, right, with that knowledge to get ready.
Most definitely.
Yeah.
Most definitely.
Yeah.
Welcome to MENO with Jacqueline Buckingham, the authority on menopause, perimenopause, and wherever you are on the pause spectrum. I'm Jacqueline Buckingham, founder of MENO, and firm believer that menopause is status, not a sentence. If you're here, something in your body or your life is asking for your attention, and you're not meant to navigate that alone. In our first 2 seasons, we started this conversation, won an Anthem Award, and brought you the leading experts before they were on Oprah. Now we're raising the standard. Each week, I bring you the verified providers, menopause specialists, and authorities you need to understand what's happening in your body and what to do next. From the gold standard in HRT and the little pink pill for sexual desire, to the conversations no one else is having about relationships, identity, and mental health. This is the full picture of your health, because this stage of your life is not just about symptoms. This is about how you live, how you feel, and how to embrace it all, because you have arrived. Pausing or not, start here. This is MENO with Jacqueline Buckingham. Today's episode, we're diving into an often underappreciated topic in healthcare. That's mental health, with our highly esteemed guest, Dr. Allie Sharma. Dr. Sharma is a Cornell-trained and board-certified psychiatrist, behavioral health strategist, and mental health innovator. She's also the chief medical officer and co-founder of Being Health. With a diverse clinical background spanning from emergency psychiatry at Columbia University to supporting the mental health of the homeless population in New York City, Dr. Sharma brings a wealth of experience to her practice. She's also an advisor for Evernow, a menopause care company, and program advisor for Kenneth Cole's Mental Health Coalition. As a mother of 2, Dr. Sharma understands the importance of holistic mental health care. Join us as we delve into her innovative approaches and impactful initiatives, a true leader in reshaping mental health care. Hey, am I depressed? Or am I perimenopausal? Or hey, am I depressed? Or am I menopausal? That's, I know, a big question just to start with, but I'm going there.
Let's start with the basics.
Yeah.
So we know that menopause is defined as 1 year after your periods stop.
Right.
Okay. Clinically, we learn in medical school that's age 51, and maybe you get hot flashes with it.
Sure.
In my psychiatry training, I learned 0 about the menopausal transition.
Wow.
Yes. So that's an opportunity for growth right there.
Yeah.
But I've learned from my patients, from clinical experts, from the research, from the evidence and what we know. So the way to think about it is that perimenopause, those are the years leading up to the menopausal transition, right?
Okay.
The time where our periods stop.
Okay.
It starts mid to late 30s and goes through our 40s. That's actually a lot of time.
It's a lot of time.
Exactly. And
Yeah.
I don't think people know that.
Oh,
right?
no. Are you kidding me? In my mid-30s, was I aware that I was perimenopausal?
Yes.
Absolutely not.
Exactly. And it's also the time where you might be having a baby, So
Yeah.
are people postpartum and perimenopausal? That's a whole nother question.
Ooh, yes.
Yes. But going back, so perimenopause is a time where your hormones, progesterone and estrogen, they start to fluctuate. And over time, they decline. So the fluctuation is like this, and it goes down over time.
Yeah.
And so therefore, if you think about the mental health symptoms associated with perimenopause, they're linked directly to these fluctuations in estrogen and progesterone, because we know that estrogen, for example, is linked to the metabolism of serotonin, norepinephrine, dopamine, all those neurotransmitters related to our mental health.
Yes.
Right?
Yes.
So mood, anxiety, all of it. And then progesterone is actually, it works on the GABA pathway. The GABA pathway is the one that alcohol is involved in, or benzodiazepines like Xanax and Valium. So it's a calming hormone.
Which is why we take it at night if we've got a supplement.
Exactly.
Okay.
Exactly. Because it's sedating.
Yeah.
And it's has anti-anxiety properties. And so if you think about it, if those hormone levels are fluctuating or declining, you're going to have a decrease in serotonin, norepinephrine, GABA receptor activity.
Sure.
And therefore, rates of anxiety and depression can be really high, as well as insomnia. And you probably saw the headlines in the last couple of weeks, but actually the rate of depression compared to premenopause to perimenopause can actually be 40% higher in terms of the risk. So perimenopause is associated with the greatest risk of depression.
Which makes sense because you're having so much fluctuation.
Exactly. And also estrogen exerts a complicated influence on the brain. The brain is also involved in depression.
Yeah.
We don't know the exact science, but we know that there's an impact. And so there's all these different levels where estrogen plays a strong role in regulating our mood. So here's the thing that I like to tell people and also clinicians.
Yeah.
If you've never had a depressive or anxiety episode, that impacted functioning, and you start to experience new onset symptoms in these perimenopausal years, let's say 35 to 55.
Yeah.
It's probably most likely due to these hormonal shifts in whole or in part, right? Because it's complicated, the pathophysiology of it.
Yeah.
Right? But that's the way we should think about it. Like the perimenopausal years are a risk factor for depression, anxiety, insomnia, stress, and many other things, all the physical health changes related.
Right. Okay.
So we need to know that. And I think if we know that, we can prepare ourselves, right, with that knowledge to get ready.
Most definitely.
Yeah.
Most definitely.
Yeah. Now, the other side is that if you, for example, have a history of depression or anxiety prior to 35, you're more likely and more vulnerable to those symptoms happening again and potentially stronger.
Okay. So we could be, if someone's feeling depressed and I am 37 years old, I may want to not just go straight to the psychiatrist, but I also might want to see a menopause expert. How would I get that? How would I get that diagnosis? Because if I go see the psychiatrist, if I'm feeling depressed, and the psychiatrist, as you are a psychiatrist.
Yes.
And if I say to you, I'm your patient right now and I'm 35, which I'm not, I'm 49 and I'm loving it, is if I said, I'm listing all of the symptoms that would be on like the DSM. I'm not interested in activities anymore. I'm eating less, I'm sleeping more, right? All of those things. If you're a regular psychiatrist, are you going to think to yourself, oh, it could be perimenopause?
That's a very good question. And I think we're going in that direction of being able to educate providers. And a lot of my psychiatrist colleagues know this, see this, they're reading and they're learning, right?
Yeah.
And then some also don't think about it, right? So I think that's an opportunity in terms of our education and our medical training.
Right.
But also, just to be very honest, care needs to be very personalized to the individual.
Yeah.
Right. So there might be other risk factors, so perimenopause, that menopausal transition is one risk factor. But let's say someone has a history of depression and anxiety and mood disorders in their family. That's another genetic vulnerability.
Right.
Let's say they have early childhood adverse experiences. That's another risk factor. Mm-hmm. Let's say they have traumatic brain injury. That's another risk factor. So as psychiatrists, we really assess all the different various parts of one's life and ecosystem that confer risk.
Right.
But the way I like to think about it is that period of our lives, we're more at risk. And if we all start to think about that, then we can think about how we design our care models. So look, the idea care model for me, from what you were saying, which was, I know you were going there, is actually a collaboration between, right?
Yes.
Between a mental health professional who's trained in this, as well as a prescriber for HRT or a menopause specialist.
Right.
That's the dynamic duo or trio if it's 3 providers. And we're getting there. We're just not there yet.
Yeah. Interesting. At the conference yesterday, people were asking, what can I do? And something that frequently comes up on the show too is, how do I talk to my doctor? And we're used to thinking that our doctor knows more than we do. and not as much, trusting what's going on in our bodies. But I believe that we've got to get as educated as possible from the doctors like yourself who know about this, who actually are seeking that knowledge. So if I'm seeking out a psychiatrist, I'm going to say, what do you know about menopause? What do you know about this connection? Do you have connections to menopause specialists?
Exactly. And I that would be a dream that every psychiatrist could say yes.
Right.
But probably not yet.
Probably not, because you said you got zero training in your psychiatry. So you got, it's hot flashes in med school, but then when you did your psychiatry residency, it was like, we're not spending any time on this.
Exactly. And hopefully that is definitely changing, right?
I hope that's changing. Yes. I think with, researchers like Lisa Mosconi, who's getting, so much press on the menopause brain and getting dollars funded that way. I really hope that's the case too. But until then, what I'm, building here with this podcast and with this audience is get the information.
Exactly.
Start with these people and then branch, start to learn some basics. And so that's what I want to learn more about from you, is basically how we can advocate for ourselves as patients so we can get the right treatment. And hey, look, if I am perimenopausal and I'm also depressed, maybe the antidepressant's going to help me. But also, if I'm perimenopausal and I'm depressed, then if I'm on an SSRI, that could decrease my libido. And then therefore there could be a snowball effect of other symptoms from that.
I'll just tell you some examples of what's happened even in my practice. So even if I recognize that someone's perimenopausal, and let's say it's someone that's had anxiety or depression, and now their symptoms are surging in the context of looking like they're perimenopausal, irregularity of menses and certain other symptoms.
Yeah.
What I do, because I'm not a prescriber of HRT yet, but I have to send them to their OBGYN. So of course you go to your OBGYN that you've had for a while. And often my patients will come back on the pill and I'm like, no, that's not what I meant. And it's hard to find the prescriber of HRT. And the pill, you probably know, it's high dose, and it's not a bioidentical form of the hormones. And it shuts the cycles down, as opposed to it being the menopausal dose, right? Or the perimenopausal dose, which is a much smaller bioidentical form.
Yeah.
And so I've had this like revolving door where people come back after like 6 weeks. I'm like, oh, you should have called me. That's not what I meant. They were like, well, they said I'm not in menopause, so I can't have HRT. And I was like, okay, now let's go to my directory of menopause specialists from Mary Claire. She has it on her website.
Yes.
Other people I know in New York City, there's great integrative OBGYNs.
Yeah.
So just through my network. And why don't you consult with one of these or the digital menopause care companies that are out there? And so then we go down that route. But it is a process. And I feel bad because it is frustrating for people to find the right care. Even when I'm helping and I'm an expert in this space from the mental health side, it's not easy. So I think it does go back to what you were saying. You need to advocate for yourself. We need to educate ourselves, like by listening through this podcast and other trusted experts.
Definitely.
And just learn what the symptoms are.
Yeah.
So you said something about medications and treatment. There is a place for SSRIs. And, I think, again, it's individualized. So I can't speak to like, there's no one size fits all solution, right? So someone might need to be on, let's say, HRT and an SSRI.
Yeah.
My point of view is, yes, there are high rates of side effects from the SSRIs, but a lot of people in my practice don't experience those side effects. And my point of view is, if you're experiencing side effects of any sort, that's not really great. Like that, and if it interferes with the quality of your life, then we're going to change course.
Yeah.
So that's how I see things. Like, you don't have to suffer with the sexual side effects. There's actually lots of other options. And if you try a different medication, it might be possible that you don't have the sexual side effects from that medication.
Right. Or like with an SNRI.
Yes, exactly. So SSRI, SNRI, there's a medication called Wellbutrin. Like, we have a couple of options. And there are other treatments for depression as well. Like,
because they're working on different things, right?
Yes,
One's working on serotonin, the other's working on norepinephrine.
Exactly.
And dopamine.
Yeah, and they're different molecular structures, even within the same class. So in my clinical experience, I can even switch within the same class, and sometimes the side effects alleviate.
Yeah.
So that's the good news. Like, I think, so in answer to your question, everyone listening out there, if you're having serious sexual side effects and you know that it coincides with the timing of your medication or any dosage increases, and there is that correlation, then speak with your prescriber, because you can feel better. You don't have to suffer through.
Yeah. Yeah. And I why I asked that question in part was because I was just talking to Cindy Eckert, who developed Addie. And what we talked about is a third of women have been or are on an antidepressant. And then therefore, some of them are on SSRIs, which do decrease your libido, just, through clinical trials. Not everyone, but perhaps that could be a side effect. And then that, of course, leading to the other issues, because as we were talking about yesterday, sex is part of life. None of us would be here without sex.
Oh, absolutely.
And a lot of women that I talk to are kind of like, no, I don't do that anymore. And I'm like,
No, it's so sad.
Wow, that's interesting. And so I often wonder about that connection between depression, medication, perimenopause, and sex, and being able to navigate that better. That's what I love a takeaway to be from this chat is like, oh, there are other things at play. I've got some new language that I can use. I've got some new resources I can use and a little bit of knowledge I can throw out there.
Yeah. So here's my answer to that.
Yeah.
And if you look at some of the data, there isn't enough research on this.
Okay.
But we know that in the time where HRT has not been prescribed because everyone was scared by that study.
Yeah.
Doctors needed to help women, let's say, or people going through the menopausal transition.
Right.
With their anxiety and depression. So what tools did we have? SSRIs, SNRIs, benzos, right? And other anti-anxiety medications. Yeah. And apparently, but I think we need more research on this, the prescribing of those medications in the time where HRT was not a standard practice anymore, skyrocketed. So the take home for me as a clinician is new onset anxiety and depression and insomnia during the perimenopausal years. Maybe we need to think about HRT and looking at the root cause as a biological shift creates vulnerability, and maybe HRT is a possibility, or non-hormonal menopause treatment.
Got it.
And then possibly also an SSRI, SNRI, and anxiety treatment just based on who that person is.
Yeah.
But I think now with this surge in knowledge about HRT being much safer than we thought 30 years ago,
right.
Hopefully things will change. And so going back to what you said, if you are depressed and anxious, we know libido decrease can be one of the symptoms of that.
Yeah.
And let's say you treat it with HRT successfully, that's going to help a lot of your sexual functioning in many different ways,
right.
Psychologically and physically, right? So I think we're talking about a prevention-based approach just by having HRT back as a tool in our toolkit. Right?
Absolutely.
Yeah. So as a patient, just know that there are these options. Go the menopausal treatment route, which could be hormone, non-hormone, and go the mental health route. It's really just try and get 360-degree care. And I think at this moment, it might be you crafting that and finding the best specialist to help you. But hopefully we're going towards more of integrated care models.
I think we are definitely going there, which is most definitely what I want to also talk to you about is being health, what you've created. But I'm so happy to know that there are so many more options for us. Hence, you being here is to learn more about what is the option you've created. Because some people are like, I want, an option that takes my insurance, or I, want an option that is integrated, or I want an option that's purely specialized. But happily, there are so many of these options. So what led you to find Being Health?
It's sort of a dream I had 20 years ago, 25 years ago, of having an integrated clinic, with a little bit of East-West or different models of treatment and care under one roof. And then the reality was, as I was providing care in my practice, but also in other systems of care as a psychiatrist, I have a specific scope. And it can cover a lot, right? Because as a psychiatrist, we assess the whole person. We think about an approach that really takes into consideration all of who someone is.
Yeah.
But our scope is still limited. And I found that I was referring people to a dietitian or to a functional medicine doc or, to mind-body methods that are a little bit different, but do help people. And so I wanted to create that system of care under one roof because I could never really speak with those other providers, or it felt fragmented. I'd send someone there and I don't know what really happened. So I wanted to just put it all under one roof where the providers are collaborating, where we're all talking and we're looking at best practices. And we're really thinking about a 360-degree view of the person, like mind, body, and lifestyle, when we think about treatment and care. And so we spent 2 years planning out the model for Being Health. And then we launched in January. And I have a wonderful medical director, Dr. Hudson Elmore, and an incredible team who really believe in what we're doing and come from this model of it's not just mind and psyche, it's mind, body, lifestyle, it's everything, right?
It's everything.
And it needs to be integrated. And so what we've created is a mental health practice, a modern mental health practice. So it has a mental health lens, but we have psychotherapy and psychiatry. We have novel treatments. So the first is ketamine infusion therapy for treatment-resistant depression. We will add others as they come on the market. We also have functional medicine, and we have wellness services. And the two we have are functional nutrition and acupuncture.
Oh.
Yeah. And we're in the financial district and we're telehealth enabled. So right now we're working in New York and New Jersey, but we hope to, over time expand. But it's been an incredible experience so far. And I have to say, I hope this model of care, by us showing data, through evidence and really great outcomes, I hope this is something that we can replicate because it works. And hopefully we can offer things like an integrated care model for menopause, for example. I think there's lots of possibilities here. For example, nutrition is one of those that I think, a lot of people are like, I know how to handle my nutrition, but actually do you? And it takes a little bit of time to figure out, what am I doing wrong? What am I doing right? Why do I have inflammation? Did you look at the amount of wine you drink? There's certain things that people don't realize. And so, for this month, actually, we're offering nutrition assessment as free as a part of any consultation, just to see how that goes.
Oh, I like that.
Yeah. So, because I think it is something that people need to look at. Food is medicine. We are what we eat. All those, old sayings. So that's one example of many of the ways we're thinking about this integrated care model.
Really interesting. So you have the nutrition part. I love that you've got the acupuncture part.
Yeah.
And then also to have ketamine in there is really interesting.
Yeah.
So how does that work? How does a patient get to that point where I'm coming to your office and I'm getting a ketamine infusion?
About 30% of people with depression have something called treatment-resistant depression.
Okay.
What that means, technically, is that you've had 2 failed trials of antidepressant medications during that episode of depression. So it just hasn't worked. And so then someone could be eligible for ketamine. Of course, we look at medical risk factors, substance use risk factors, as well as psychiatric risk factors. So it really is that. So it's treatment-resistant depression. We also will accept people are eligible for services if they have treatment-resistant anxiety with treatment-resistant depression, and also PTSD with a significant mood component, treatment-resistant depression. Those are the 3 criteria in terms of what we see. And a lot of time it comes from referrals from outside providers or other healthcare practitioners or even therapists. Or it can be self-referrals. Some people know, I've tried everything and I really need help. So people can self-refer as well.
I see. That's interesting. And then would it be a course of infusion treatments?
Yeah. So there's something called a ketamine induction series. And the science shows us that a good practice that's been replicated in the literature is 2 infusion sessions per week for 3 weeks. So that's 6 infusions.
Okay.
And they're about 40 minutes. And we also integrate it with what we call ketamine-assisted psychotherapy. So we have at least 1 session prior without the ketamine. So you're preparing, setting intentions, talking about maybe past traumas or things that you want to think about in the sessions or to come up. And then we have integration sessions, at least 3 afterwards. But that can be tailored to someone's needs.
It's really interesting.
Yeah. And that's really important for ketamine treatment, to integrate it with the therapy, because that's how you really have the best outcomes. And just like any medication in psychiatry, actually, if you have psychotherapy with the medication, it usually shows better outcomes than either alone.
Yeah, exactly. What's happening in the brain during that infusion?
Yeah. So look, ketamine works on the glutamate pathway, and it facilitates neuroplasticity. So although the exact mechanism is not known, we know that it is a rapid antidepressant from trials, from these research studies. And it's so rapid that you could feel better within 90 minutes to 2 hours of the session. And then there's something called a neuroplastic window, which is like, the time, let's say the 24 hours right after the infusion. And that's why we try to have a session within that 24 hours to kind of facilitate that neuroplasticity, meaning the changes in your brain and the new neuronal connections. And that's really exciting. So that's different from like thinking about depression as like an issue of one neurotransmitter, like serotonin only.
Yes.
It's about brain health and the brain impact of depression and fixing that. So it's a little bit of a shift in terms of the root causes of depression, in terms of how we're looking at it.
It's really fascinating. It really is fascinating. I'm happy to see that it is part of this holistic model that you've built with Being Health.
Yes. And it's not for everyone, right? Like ketamine and psychedelics. I know there's a renaissance right now, but it really isn't for everyone. There are adverse consequences in some people. But yes, we wanted to build it and embed it in a integrated system of care so that that's one tool in our toolkit to help this person over here, but someone else might need maybe therapy and acupuncture, or functional medicine to identify root causes in terms of their physical health.
Who might not be a candidate? What are some big red flags where you'd be like, nope, not for you?
Yeah. So uncontrolled hypertension, for example.
Okay.
People who have a known allergy to ketamine.
Okay.
People who have a substance use history, right? In and out of rehabs. For example, those are a few. There's more, but also serious medical conditions. There's some contraindications.
Interesting.
Yeah.
So acupuncture. That is such a powerful medicine.
Have you done it?
I have done it. I had an experience where I didn't have a period for 2 years. Went to see this doctor, that doctor. I was young. I was in my 20s and got referred to this acupuncturist in Chinatown here in New York City. I could like hear my body working when he was putting those needles in, which didn't hurt. Really didn't hurt at all. I remember he put a light on them. And I mean, this was, my God, over 20 years ago. So I didn't really know what was happening, but wow, I felt it in my body. I felt those shifts. And it really made me actually start to look into Chinese medicine and Ayurveda and some ancient systems that have been around for a lot longer than our Western ones.
That's fantastic. I love hearing that. My story is my OBGYN from Cornell, which is where I trained, said to me when I was trying to get pregnant, like late 30s, it's like, why don't you go for acupuncture? There's some data. And I was like, oh, that's so cool that you're endorsing that. I'm open to that. And I've done acupuncture. So I actually went to a fertility specialist in acupuncture. And for both of before both conceptions, I had 2 months of acupuncture. And I swear it set the stage for conceiving, right? So that's how I really entered into it, more consistently and routinely. But the amazing thing is the WHO, the World Health Organization, endorses acupuncture for over 100 health conditions, and depression is one of them.
I did not know that.
I know.
That's the World Health Organization? Yes, WHO.
Exactly.
Thank you.
Exactly.
Hats off for that statistic.
Exactly. And so us as an integrated practice, like psychiatrist-led, we're also we have these, maybe an Eastern method, but we're looking at the Western data and how we understand it. Right?
Absolutely. Yeah. I'm all for bring it all to the table.
Yeah, exactly.
On this menu, let's have this be a multicultural offering.
Exactly.
Why not?
And we know from the studies that acupuncture can help reduce severity of depression symptoms. It can actually enhance the effects of the SSRI and improve quicker. Also can help with anxiety, insomnia, stress, and pain, and many other things as well. But I often have referred people to an acupuncturist, right? Who I feel are open to it, who maybe feel it also in their physical body. And, just anecdotally, it sounds like you described it too, but I find it a great nervous system reset for me. Like it just gets me down to a baseline, and I find it a form of self-care for me as well.
Definitely. Well, we are subject to all of the environmental stresses, whether it is a, fire engine that blows past us on 39th Street, or whatever, or something actually that we're reading, something that we're watching on TV. So it's maybe not just what's happening like, oh yeah, my marriage is good. I like my job, but we're subject to all of these other things. And I consider us to be very porous people, maybe some more than others. People call it sensitivity. Yeah. But I do agree with you that acupuncture has a place, not just for, I'm going to do acupuncture for, the amenorrhea, but also I'm just going to do it for resetting my nervous system. Because, correct me if I'm wrong, we haven't seen a lot of adverse reactions from acupuncture. Would you agree?
Yeah, I would agree. When we created this model and we're doing our due diligence and the initial research, there aren't so many adverse effects. I haven't, maybe sometimes people feel a little nauseous, or you might bleed a little bit from where the needle was placed. Yeah. But yeah, minimal reactions, it seems like.
And so when you're really focused on depression, where are you putting those needles?
That I would have to consult with my acupuncturist.
Because I was just thinking about that. I was thinking, okay, I know where they were on me. And some of them were in interesting places. Like, oh, and this one's on my toe. And I'm like, what? Yes. But, anybody who looks at Chinese medicine and actually looks at the systems, it's all connected. It's really interesting. So I was just kind of wondering. I was thinking like, are they in your head? Are they in your forehead? Are they in your neck?
So again, because even in Ayurvedic medicine or Chinese medicine, mood and psyche are integrated, right, into how they conceptualize the body. And so it's not like you would have a certain set of points for depression, because also the way everyone experiences depression, there's so much variability to it. Right. One person might have sleeping too much and eating too much. Another person might have insomnia and severe irritability, anxiety, right? So the acupuncture will tailor the treatment programs and focus on the meridians that really correlate to the symptoms that the person is presenting with and how they're presenting, right? In terms of their skin, their integument, their tongue, right? Their pulse, and all of the way they physically, observe the body. So interesting. It is. And it's interesting because in these rounds, we speak different languages, but then we realize there's a commonality to what we're talking about.
Right.
We're talking about the same condition, but like using different language. Right?
Exactly.
It's like 5,000 years of clinical trials, right? In China, basically. So they did something right.
They did something.
Yeah, exactly.
Yeah, definitely. I like that you also offer what we think of as more traditional, which would be psychiatry, and that's us talking.
Yes.
Or you as the psychiatrist prescribing medication of some sort, whether it's anti-anxiety or antidepressants or whatever.
Yes.
Would make sense.
Yes.
And so is that part telehealth? Can I be in California and do telehealth with someone on the Being platform?
So right now our providers are licensed in New York and New Jersey, except for our functional medicine provider. And some of our providers are licensed in other states as well.
Okay.
It just takes a while to kind of build the licensure. So right now we're starting in New York, New Jersey, and then hopefully we will expand. And our services, most of our clinicians can be seen in person, except for a few downtown in the financial district, or by telehealth.
Okay. Interesting. Yeah. All right. So if someone's curious, just, go to is it beinghealth.com?
Yes. Beinghealth.co.
Beinghealth.co.
Yes.
And you can get in touch and ask questions about, here's where I am. Do you have somebody here?
Yes. We have like an option for a 15-minute call that's free of charge with one of our clinicians.
Interesting.
Like, don't know what you need. So talk to someone.
Back to perimenopause and menopause for a moment. Where did you get your training in that?
Sure. So it's really interesting. I think I started my practice in 2008, and I was working in different systems of care, like in the psych ER or the CPEP at Columbia.
Okay.
I worked in the homeless population. I worked in student mental health at Columbia. I worked globally. I was a WHO consultant. I was working with trauma globally in post-conflict countries, worked in the Bronx, ran services there. So really the work across so many systems of care, especially the work abroad, you come across trauma working with women, and women, half of the population, is going to menstruate or has been menstruating.
Yeah.
And you learn from your clients. Like, you see the patterns of how things present, and also I think what happened was, because I'm a psychiatrist, a lot of people tell me lots of things, lots of private things. So I learned, this friend who's 10 years older, she went through a severe depression when she hit menopause and she was shocked. No one told her that.
Yeah.
Another one couldn't sleep and insane amounts of stress. And so you you listen, you're learning all the time as a clinician. And then I started looking at the studies or, just seeing what's out there and seeing my patients and how they evolve. And then I became an advisor for EverNow. And I really dug into the literature and research, which is pretty scant, to be honest. It took me a long time to figure out, all right, let's understand the pathophysiology, because I didn't learn this in medical school or residency. So it's been my own research as part of being in the EverNow community and also going to conferences and learning from experts. So it's a constantly iterative process where I'm learning and trying to teach others as well. Even my team at Being Health, for example.
Sure.
So we're going to start an internal program so that people are sensitized in this phase of life. Because for me, it's really about how do you be an excellent clinician across all phases of life, in the life cycle.
So true.
Right?
When you reeled off your breadth of experience, clearly you would get so much data from being in that.
Exactly.
I mean, what better experience could you have? What better expertise could you have other than experience?
Exactly. And you learn, right? We're like constant students as physicians and as providers. And that's really how it just evolved that way.
It's very cool. So what drew you to EverNow?
It just happened through a friend, and I looked at what they were doing, and I just was like, wow, this is an unmet need. And I've always done work like in the public sector, for example. That was the first 10 years of my career on representing people who are marginalized or populations who are marginalized, whether that's in Afghanistan, civilians who are affected by the war, or in the South Bronx, right? People that are affected by poverty. And I just feel like that underrepresentation, there's so many challenges when that happens. And then I felt like, wow, like menopause is this as well, and it's neglected. It's not understood. We need more research. We need to shed a light on this. And that's really why I do it. And I love elevating these kinds of topics. I think it's really important.
For those of us who don't know what EverNow is, can you say what it is?
Sure. So EverNow is a digital menopause care company that's really focused on 360 care. And it is really rooted in research. They do excellent research. They're led by Dr. Alicia Jackson, who's a scientist. She's incredible. And I think they're in most states. So it really is a low barrier of entry in terms of getting care.
Are they an insurance model?
So there is a price per month model.
Okay.
And it's like something like $25 or $30 per month. And then through your insurance plan, the medications are covered. That's depending on your plan. So they will send it to a pharmacy that's covered by your insurance.
And they're really focused on HRT. And really specifically menopause care.
Yeah, exactly. And now they have a partnership with the mental health vendor Talkspace. And they have other offerings as well coming up. So their goal is to really provide that 360 degree care.
Interesting. Would you say what sets them apart from others is the research?
The research and the accessibility.
Okay.
For sure. Yeah. And they have an app. It's very easy to text your provider. I mean, it was a great patient experience for me. So I actually tried it. Yeah.
I'm trying these things so I can share.
Yes, exactly. From the user end.
Yeah, I am. And I've tried some and so I'll try that one.
Yeah.
And I haven't yet.
Yeah. And I'm an advisor for EverNow. The other one I've come across is My Alloy. I met them at the conference where we were presenting. And so, I think just find something that works for you.
Find something that works. Exactly. Yeah. That's Dr. Sharon Malone. She's in that episode. We really get into HRT and why it got taken off and now it's back and how to make some sense out of it. We really break it down. I'm just so happy there are these options.
Yes.
And I say this and I'll say it again. Like, my goal on the show is not to say, this is the option for you. It's her. This is it. It's being. No, it's to say, here's an option.
Yes.
And here's another option.
Exactly.
And, here's this expert and here's another expert.
Exactly.
Because we are in a moment where, thank God, all of these things are coming to the market. Menopause is getting attention. Thank goodness. Women's health is getting attention. Yay, Halle Berry. Like, oh my God, that was so exciting. And at the same side, or on the other side of that, is we have all these choices. And so sometimes those choices are, oh my God, which way do I go? Is it this one or this one? And my answer to that is just get in there.
Exactly.
Just get in there and try some things and see what works. See what works for you.
Exactly. And I think the other thing is that I've learned when we are talking in these small groups is a lot of people have been feeling excluded from the conversation.
Yeah.
Let's say you're a breast cancer survivor and the healthcare profile is not great for HRT, but there are other options. And that's what people don't know, right? There's vaginal estrogen or think about the people who may not be able to take it and then are worried about the health risks. What about nutrition, right? Which can also really reduce risk of disease and other things, right? And lifestyle considerations like exercising and movement and taking care of yourself. So there's a lot of other ways we can tackle it if HRT is not an option. And then cognitive behavioral therapy for menopause is another one, or for insomnia.
Ooh, let's go there.
Yeah.
What does that look like?
I've learned through my menopause colleagues that there is a specific form of cognitive behavioral therapy for menopause. However, if you're a cognitive behavioral therapist out there and you think about the distress around hot flashes, for example, and vasomotor symptoms that some people may have, there's a lot of psychological distress. It causes anxiety if you're in the workplace and it comes off, or it happens at night. And cognitive behavioral therapy can be a great way to manage the distress around the symptoms and has been shown to be effective. So that could be a non-hormonal treatment for vasomotor symptoms or for other menopausal symptoms related.
And really, that's kind of changing your mindset around what's happening.
Yes, exactly.
So rather than maybe like a little bit of panic, maybe a little bit of shame, maybe a little bit of embarrassment. Oh my God, I'm at work and I'm sweating through my clothes, or I'm just feeling terrible. And all of a sudden my face is red, and like really, that would be very stressful. And then all of a sudden you're thinking, am I going to lose my job?
Exactly. And we can spiral, right? And
absolutely.
CBT is great for looking at those events that make us feel vulnerable, whether it's the symptom or a thought.
I love that. I feel like that should be discussed more. There is such a focus on HRT, which of course has a very important role, but the specific cognitive behavioral therapy for menopause symptoms, even perimenopause symptoms.
Exactly.
I feel like we should all do that.
Exactly.
Because that's changing a mindset about what's happening. And instead of, having the shame, having the embarrassment, just going, this is biology that's happening. It's like a storm. It's just like, this is happening. And so you get rained on. So, so you're sweating a little bit. It's just what's happening. But our reaction to it, that's what is so shaped by society and what we've been taught and kind of taught how to feel.
Yes, the way we're wired. And it can affect how you feel, and then it can affect how you behave.
Sure.
Right? So you may not go out to that event with friends because you feel ashamed or worried, or you may do something else that you wouldn't otherwise do. So absolutely, it's deconstructing, how you behave in response to how you feel in response to that event or thought or symptom.
Wow. So out of all of these things that you do, what is your passion? What do you love doing the most?
So what I love, which people might kind of laugh at a little bit, but I love helping people with anxiety, depression, and stress and trauma. Yeah. Those are the 4 things we're focusing on.
Yeah.
Because it's so treatable. It's complicated. It's nuanced. And I love trying to figure out, all right, this person has this profile of things. Let's figure out how to pull them out of this crisis or this episode.
Yeah.
And it's so gratifying to see people get better. Like that. I love when people leave my practice because that means they're getting better. Hopefully, if they've gotten better.
Yeah.
Because that's what you want. You want to see people feeling better, functioning better, leading the best lives. Like that's what makes me.
Sure. Or even if they decide to stay.
Yes.
Because it's working.
Oh, yes.
And it's supportive in my life.
Oh, absolutely.
And it's like, I'm not leaving this. I'm not changing this. I'm not getting rid of this very supportive, intelligent, highly trained person.
And I have the range. I have people that have been with me from the beginning. I have people that have been there very short term. So it really is the whole spectrum, like you say. I think it depends on the person.
Yeah,
it depends on what someone needs.
Well, you do so much, and yet you also find the time for advocacy. And I know that you've been involved in what Kenneth Cole is doing.
Yes. So I am a program advisor for Kenneth Cole's Mental Health Coalition, which is an incredible group. Kenneth Cole and his daughter, during COVID had convened a lot of the mental health stakeholders, and that represents the coalition. And there's about 6 of us on the program advisory board. And they're doing such great work. The IG handle, which I think everyone should know about because they have a lot of incredible resources, is Mental Health Coalition on Instagram.
Okay. Right.
And take a look at it because their branding is so great. It's accessible, it's relatable, and they offer a lot of resources and across the spectrum, like in terms of marginalized groups, all socioeconomic levels, thinking about, inclusion in terms of race, gender, religion, livelihood, et cetera. And they're really doing wonderful work, and they've been working even in tech more to just think about regulations and just wonderful work. And I really commend Kenneth Cole and his daughter because they've taken on something that's difficult, I think, to
Definitely
make beautiful and make accessible to the public.
I love that you said make beautiful. It's, it's like, okay, that does make sense. To have a fashion designer, show us how it can actually be a beautiful thing. Really, the more knowledgeable we are about ourselves, trusting our bodies, trusting those signals that our bodies give us, whether it's, hey, maybe I am depressed, or hey, maybe it is just perimenopause, is where we start. And then approaching people that you're comfortable with, people who are trained, and then finding a model that works for you.
Absolutely. And I think that first step, which is what you're talking about, is awareness, right? And how do we self-refer? Meaning, how do I even know what's going on with myself?
Yeah.
And when is it time to ask someone for help? Or when is it time to go look for help on the internet, just with more information?
Sure.
And I talked about that yesterday at the summit. And, I think the 2 things are if you feel different from your baseline. And that could be perimenopause, right? Or an episode, right? Or a time of high stress. If you feel different from your baseline and you're just not feeling like yourself, even if you can't put a finger on it, that's an indicator. If you're not sleeping, that's also an indicator. And if you're having trouble concentrating for whatever reason.
Yeah.
Simple concepts, but I think important ones.
Definitely. I like that. If you feel differently than your baseline and having that awareness.
Yes.
And truly, and I believe having that trust, really reconnecting ourselves with our bodies and trusting what the signals are telling us, because our bodies are telling us things all the time.
Yes, exactly. It's like little alarm bells, right?
I'm like, it's like, look, I'm definitely, the person who's like, if my foot hurts, I'm not going to run through it.
Exactly.
I'm like, I think I'll stop walking.
Exactly.
I think I'll have a seat. And a lot of the conditioning that I know I got, I feel like we all got it, was like push through, which really does say negate everything your body's telling you.
Yep. That's a whole nother conversation about culture and what social norms and how we're taught to like march on. And I think, in our training, we learn that like expressing vulnerability is a strength.
Yeah.
Right? As saying that you need to stop and take care of yourself is a strength, not a weakness. So we need to reverse the narrative and reframe it. Yes. Especially in New York City.
Yes, most definitely. I lived here on and off since 1998. And so it is definitely like one of my homes. And whenever I get to come back, and I love being back, I'm like, oh my God.
I know, especially in this neighborhood.
And here we go. And scene. Like, yeah, exactly. It's like,
intense.
Oh, wow. It is intense. And life is intense. And I don't think there's any of us that are free from, there's nobody that's free from stress.
No.
It's just a matter of like, how are we handling it? What are the tools we're using? What are the tools that are available to me? And I do believe first and foremost, trust your body, trust what your body's telling you. Trust your instincts also when it comes to who you seek out.
Yes.
And, if you don't like what they're telling you, go somewhere else.
Yes.
There's options.
I had to do the same. A great Ivy League institution.
Yeah.
I couldn't get what I needed and I had to go seek help too. So just, it happens even to the best of us, right?
Exactly.
So it's okay.
Exactly. Or even if I was seeing one of your clinicians at Being and I was like, you know what? This one's not the right one.
Yeah.
Maybe it's another one. right?
Agreed. I think, it's so personal what works for you. It's also personality and dynamics and interaction. And you have to find the right person for you, especially when it comes to a therapist or a psychiatrist, but even a medical doctor.
Yeah.
You have to find someone who really fits.
Definitely. Well, I so respect the incredible amount of training that psychiatrists go through, achieve, accomplish, conquer, etc., to get to where you are. It's a tremendous amount of school. It's a tremendous amount of work.
Yes.
And I just thank you for sharing your knowledge.
Oh, you're so
you got a lot of it.
No, and thank you for asking, right? That's part of it. I feel like mental health in the beginning of my career was sort of, not the center of the conversation, but it's really amazing with COVID in the background, how it really is top of mind.
Yeah.
And we're talking about it in a way that's necessary and in a way that we haven't done before. And I'm thankful, to be here.
I'm Jacqueline Buckingham. Welcome to your most powerful chapter. Wherever you are on the pause spectrum, this is where you begin. Go to joinmeno.com and get early access. These are the answers, and we bring you the experts that have them.